So in this video lecture, we're going to look at preventing unwanted blood clots, kind of related to our previous lecture on hemostasis. So we'll look at different ways to control blood clot size. So we'll look at the natural or internal mechanisms that prevent unwanted blood clots, and also then compare thromboses and embolisms and how they relate to blood clots or unwanted blood clots. And finally, some of the drugs that we use to prevent unwanted clots and how they work. So let's first look at how we're going to get rid of a blood clot that's formed. So imagine you've got a blood clot that formed in response to some vessel damage. And now the vessel's been repaired, and so we need to get rid of that blood clot. It needs to be removed from there. We don't want the clot staying there forever. The tissue's now repaired itself. So that's going to involve the use of plasminogen or plasmin. Now plasminogen is a plasma protein that's floating around in your blood and needs to be converted to plasmin. Plasmin then in turn dissolves the fibrin or degrades the fibrin. Think fibrinolysis, breaking down fibrin. So plasmin is in charge of breaking down the fibrin or degrading it and getting rid of it. If I get rid of the fibrin, I get rid of the clot. So now what we have to have happen then is that plasminogen has to get converted to plasmin. Something needs to trigger that, and that's where we see plasminogen activators. Plasminogen activators are in charge of converting plasminogen to plasmin. There's a lot of different types of plasminogen activators. One of those is tissue plasminogen activator. That's secreted by the endothelial cells when they're exposed to the clot. And they're just released nice and slowly into the clot. So all the plasminogen that's in the clot gets hit by that plasminogen activators, and as soon as those levels build up high enough, it will convert the plasminogen into plasmin, and therefore the plasmin will break up the fibrin and dissolve the clot. So the timing of this is crucial in the sense that we want the blood vessel wall to heal at about the same time that the levels of tissue plasminogen activator get high enough that they can activate the plasminogen and form the plasmin to dissolve the fibrin. Other things also work as plasminogen activators, like activated factor 12 or thrombin even in turn activates plasminogen or converts it into plasmin. So then again, the plasminogen converted to plasmin, and the plasmin in turn digests the fibrin strands up. Now there are certain chemicals as well that inhibit this pathway. There are plasminogen activating inhibitors and plasmin inhibitors. And these guys then are in charge of inhibiting either the plasminogen activators or the plasmin. So this again, if I don't have plasminogen activators, then I'm not going to get plasminogen converted to plasmin, which means I don't get fibrin broken down. Or if I inhibit the plasmin, I don't get fibrin broken down. So these guys slow down or stop the process of fibrinolysis or the clot dissolution. Now what's going to happen then if we increase or decrease the levels, let's say, of PAI? Okay, so let's say we have low levels of PAI. Low levels of this plasminogen activator inhibitor. Again, this is an inhibitor. If I have low levels of an inhibitor, I'm not going to inhibit plasminogen activators, which means I have a lot of plasminogen activator. If I have a lot of plasminogen activator, that means I'm going to get a lot of conversion of plasminogen to plasmin, which means I'm going to have lots of plasmin. If I have lots of plasmin, I have lots of fibrin being dissolved or degraded. So low levels of PAIs means a lot of fibrin or clot busting or fibrinolysis. That means, though, I've got possibly a lot of bleeding. So low plasma levels of this active form of plasminogen activating inhibitors is associated with abnormal, clinically significant bleeding. So that's not good. I don't want too low levels of this, get lots of bleeding, because I might break the clot up. If I have high levels, or say too high levels of PAIs, now I have lots of inhibitor. If I have lots of inhibitor, that means I'm not going to have much plasminogen activator because it's inhibiting the plasminogen activator. So I have very little plasminogen activator, which means I'm not going to get much plasminogen converted to plasmin. If I don't get much plasminogen converted to plasmin, I don't have very much plasmin. Low levels of plasmin means very little fibrin broken down or degraded. If I don't get fibrin degraded, I don't get rid of the clot. So I have a blood clot, a lot of blood clots. And that high levels then of PAIs means I have a lot of blood clotting. And that's been associated with things like deep vein thromboses, which is blood clots in the legs most typically, or coronary artery disease or myocardial infarctions, where you've got blood clots forming with plaque inside the coronary arteries and causing heart attacks. Other ways we look at with preventing inappropriate clots, things that could help in preventing unwanted clots, is rapidly moving blood, because then the clotting factors can't reach critical levels that would normally cause a blood clot to form. So if I've got blood flying through, those clotting factors are just going to be swept along with the blood and spread out throughout the blood, and they never in any one area get concentrated enough levels to start the clotting process. So as long as you keep blood moving, you're good. Okay, things aren't going to cause clot formation. So we want rapidly moving blood. What else that we want is thrombin trapped in the clot by being bound to the fibrin. If I keep thrombin trapped in the clot, then the thrombin can't get out and cause a blood clot somewhere else. So because remember, thrombin's kind of the heart and soul of both the extrinsic and intrinsic pathway. It feeds back on, especially from the extrinsic feeds into the intrinsic, and thrombin in the intrinsic feeds on itself to keep increasing the amount of fibrin produced. And so we want to make sure that thrombin is incorporated in the clot and stuck there and doesn't escape from the clot so that it can cause problems somewhere else. We also have a bunch of natural anticoagulants. These are things like antithrombin 3. This is a protein in the plasma that inactivates thrombin, so that if any thrombin does escape from the clot, antithrombin 3 is there to get rid of it. Think antithrombin, it gets rid of thrombin. We also have heparin. Heparin secreted by basophils and mast cells and on the surface of normal endothelial cells. Heparin inhibits thrombin and the intrinsic pathway, and so again, you're not getting unwanted clots, or you're only getting clots where you have an actual damage to the endothelial cells. So if any thrombin escapes, the heparin will get rid of it. We use heparin a lot to line the inside of blood vessel, or excuse me, test tubes or bags, so that the blood doesn't coagulate inside the test tube or bag. Nitric oxide and prostacyclin, we've already seen, is secreted by uninjured endothelial cells, and again, it prevents platelets from sticking to it so that we don't get platelet plug formation, which could actually lead to coagulation as well. Now, there are some coagulation disorders, one of which is thrombocytopenia. This is when platelet counts are too low, and so the person's going to bruise easily. The cause is anything interfering with red bone marrow. So if you've got bone marrow that can't reproduce, therefore they're going to form, you're not going to get platelets formed because you're not getting the megakaryocyte to produce blood cell or to produce platelets, and therefore your platelet numbers go down. Another one is hemophilia. This is a genetic disease where you're lacking a clotting factor, so therefore you don't get blood clotting or coagulation. This is sex-linked in males, typically because, or we see it typically in males because of the fact the males only have one X chromosome, so it only takes one gene for them to end up with hemophilia, whereas women, since we have two X chromosomes, we need two genes for hemophilia to be a hemophiliac. There are different types of hemophilia. The most common two are hemophilia A and B. A is by far more common than B. A is where you're missing factor 8. B is where you're missing factor 9. The problems with hemophilia is typically we've seen on physical exertion that causes excessive bleeding, and thereby, because of the bleeding often into the joints, it causes joints to swell, and you get a lot of pain from that. The treatment for it is going to be transfusions of plasma or purified clotting factors. Factor 8 now is produced by transgenic bacteria and that therefore you get clotting, as it shows here. When you get replacement therapy, you get lots of blood clotting, and therefore blood clots or coagulation happens just fine. Unwanted clots can include thromboses. Thrombosis is just basically an abnormal clot in an unbroken vessel for some reason. Could be because of platelets sticking to an atherosclerotic plaque, for example. An embolus is an unwanted clot that travels to another vessel. This can happen, or what can happen with an embolism, let's say we've got a thrombosis here, and that part of that blood clot breaks off and it travels. It's going to continue to travel until it reaches a blood vessel so small that it blocks that blood vessel, so that anything downstream from that blood vessel, or that blood vessel takes the blood to that organ, is going to end up causing a problem. An embolism then is an embolus, or an unwanted clot that obstructed a vessel. And there are a lot of different types of embolisms. Blood clots are the only ones, but let's for now think about embolisms related to blood clots. If you block those blood vessels, then you can end up with infarction or what's tissue death, and that could lead then to possibly it could be a heart attack, like myocardial infarction, or a stroke if it was, like, for example, on the heart or the brain. Now, conditions that favor those clots include atherosclerosis, that buildup of plaque. The plaque can often rupture and then have rough edges. Those rough edges is where the platelets can now stick and start forming a blood clot. Or slow-moving blood or blood stasis, such as people who are bedridden or sit for extensive period of time, and say in a car or a plane. That kind of restricts blood movement, say in their legs, because you don't have action of your legs moving to keep the blood circulating, and so blood pools. The clotting factors then aren't washed away. They can concentrate and form a blood clot, and that would be a problem. Pharmaceutical agents that work in helping prevent unwanted blood clots. One of these is heparin. Heparin increase the ability of antithrombin 3 to inactivate thrombin. If I inactivate thrombin, I'm not going to get that feedback on the intrinsic pathway and leading to more clot formation. So again, that's going to prevent unwanted blood clots. Heparin can't be absorbed in the GI tract, so we have to give heparin by injection if that's the drug of choice, which means it's not very likely to be prescribed for someone to help them preventing in blood clotting. Another anticoagulant is warfarin, which is also called Coumadin. This is the one you probably hear most often. Warfarin decreases prothrombin and other coagulation factors. What it does is alters vitamin K so that it's unable to produce the clotting factors, and so if you don't have a lot of clotting factors, you can't get a lot of blood clots formed. And so we can take warfarin orally, and it takes only 36 to 72 hours for the warfarin to take effect, and so it works very effectively, a quick way to decrease the amount of blood clots that may form. Aspirin is another one, often taken in low doses to help prevent blood clots from forming. What it does is reduces the production of thromboxane A2. If you remember, thromboxane A2 promotes vasoconstriction and platelet aggregation. So if I'm not going to get platelets to aggregate, then they can't form a blood clot or a platelet plug or a blood clot. And this is an actual irreversible effect. So as long as the platelet's alive, the aspirin has its effect on it. So if a patient needed to go off of an aspirin regimen, say because of surgery, you don't want excessive bleeding, it takes a little while for that. You have to get off the aspirin for a couple weeks before the surgery. NSAIDs also work. They have the same effect that aspirin has on the thromboxane A2 and the platelets, but however, the effect isn't reversible. So it only lasts as long as you've taken that drug. So like the 4 hours that you're taking an NSAID, you can have the effects of reduced clot acting. So you're not going to use NSAIDs particularly for long-term effect on reducing blood clot formations. Um, Clopidogrel, I'm not even sure if that's how you pronounce it, but we'll call it Plavix. That's the prescription or the commercial name for it. It inhibits ADP-mediated platelet aggregation. So remember, ADP is used to get the platelets to stick to one another. So if they can't stick, they can't form a platelet plug. They also aren't going to be activated to release clotting factors and cause a blood clot. So they're going to work as well. Now, one last note on this I want to make is that often these drugs are called blood thinners. Blood thinners is a misnomer. Your blood isn't getting thinner or less viscous. All it means is a blood thinner is it's an anticoagulant. It's stopping blood from clotting.